the doctors who next channel. I'm Shayanga Enas. I'll be taking you for endocrinology. We're continuing with our endocrinology series. So today I'll be taking you for endocrine pancreas. Okay. So the pancreas is composed of two parts. We have the endocrine pancreas, the one which secretes hormones directly into the bloodstream. Then we have the exocrine pancreas, the one which secretes into the gut. So, but this one does not secrete any hormones, it secretes digestive enzymes. So, let's go to the anatomy of the endocrine pancreas. We have what's called islets of Langerhans. These are like tiny clusters of cells, the ones which produce and which synthesize and secrete our hormones. So, first of all, we have the beta cells. The beta cells are the ones which synthesize and secrete insulin. We have alpha cells. These ones synthesize and secrete glucagon. We have delta cells. These are for somatostatin. And then we have F cells. These are for the pancreatic polypeptide. So the one thing to note about delta cells and somatostatin is that somatostatin, wherever it is an inhibitor. Okay. The pancreatic polypeptide, I'm not going to delve much into pancreatic polypeptide, but I'm going to put much emphasis on insulin and glucagon. Okay. So insulin is a receptor which has a tyrosine kinase activity, and then glucagon is a receptor which has a GS activity. Okay. So as for the actions we refer to three main principal sites. The first one being the liver, the second one being the muscle cells, and then the third one being the adipose tissue. Okay. So insulin and glucagon, these are antagonistic, meaning say one thing does read the other opposites. Okay. They oppose each other. So starting with insulin is anabolic. So if insulin is anabolic, glucagon is catabolic. Right. So what do we mean by anabolic and catabolic? Anabolic is like building up, and then catabolism is like breaking down. Okay. So when you come to insulin, this side, we're saying it's anabolic. Means say we are going to build up proteins by increasing the uptake of amino acids from the blood into the liver cells, into the muscle cells. Okay. As for glucose, we're going to increase uptake of glucose into the liver and the muscle cells. How? By storing it as glycogen. Then as for the ketones now. For the ketones, we are going to increase the uptake of these ketones, or increase the uptake of fatty acids from the blood into the adipose tissue. Right? So why do we do that? It's like insulin is anti-ketogenic, which means we don't want ketones in the blood. When we have too much ketones in the blood, it can lead to acidosis. So we don't want acidosis, therefore we uptake ketones from the blood into the adipose tissue. Right? By doing this, we are increasing fatty acid in adipose tissue by increasing adiposity. Okay, so I think that's all for the functions of insulin. And then for glucagon is the opposite, which means whatever insulin does, we're opposing it here. Right? We are decreasing amino acid uptake, we are decreasing glucose uptake, and then we are decreasing ketone uptake, which means that we are going to have elevated levels of proteins in the blood, elevated levels of glucose in the blood, and then elevated levels of ketones in the blood. Okay, so which means that here we are likely to have the condition ketoacidosis. Right. This just reduced blood pH due to ketones accumulating in the blood. Okay. So as for the stimuli which regulate the release of these two hormones, the endocrine pancreas is not under the direct control of the hypothalamus, which means that whatever we release from the hypothalamus, it's not going to have an effect on the release of hormones from the endocrine pancreas. So, in fact, it is under the control of like the concentration of substrates or metabolites in the blood, which means that when we have elevated glucose levels, we're going to have increase in insulin secretion. when you have elevated amino acid levels here, we're going to have increase in secretion of insulin. When you have elevated ketone levels, we're going to have increase, right? As for glucagon, the reverse is true. When we have low amino acid levels, we're going to have increase in glucagon secretion. When you have low glucose levels, we're going to have increase in glucagon secretion. It's the same for ketones, right? Also, when we exercise, exercise is a very important factor, because by exercising, we are depleting the glucose in the blood, which means the glucose levels decrease. Once they decrease, we are going to have increase in glucagon secretion. Okay. Then there's one important factor you need to highlight here: adrenergic stimuli. So we all know adrenaline. Adrenaline is for the fight or flight. Okay. So when we have adrenaline, it increases the metabolic rate. Okay. So which means to have increased metabolic rate, we need to have increased glucose levels in the blood. So how does the body convert that? When we have insulin here, insulin is anti-adrenergic, which means that adrenergic stimuli, they inhibit insulin secretion. We don't want glucose in the blood. That's insulin. Therefore, but adrenergic stimuli, we're saying we want more glucose in the blood. So they oppose each other. But when you come here, adrenergic stimuli, they increase the secretion of glucagon because you want more glucose in the blood. All right. So that's the basics on the effects of insulin and glucagon, and then the stimuli which regulate their release. So if you want to get a full grasp, you can refer to the text. But here, these are the basics. These are the principles of insulin and glucagon. Alright. So let's now come to the clinical here. We're talking about diabetes mellitus. We all know that diabetes mellitus is more common, which affects more people in the world than possibly any other disease. Right? So our diabetes mellitus is classed into two. First of all, we have type 1 diabetes, and then we have type 2 diabetes. Right? So for the type 1 diabetes, this can be called, we can classify this as primary and secondary. Because when we classify it as primary and secondary, we are saying that we have our ligand molecule here. This is our ligand molecule, and this is our receptor. For a primary, we are saying we don't have the primary, we don't have the ligand at all. This is primary. Then for the secondary, we're saying that we have the ligand, but the receptor is not working. Okay. So this is secondary. Okay, so the same applies to diabetes. When you have type 1 diabetes, we are saying that your insulin is not working. You don't have insulin at all, which means we are having a condition which is affecting the insulin producing cells here, such that we are going to have low or no insulin at all in the body. Okay. So we have low or not at all, no insulin produced. So when you have no insulin, we are going to have hyperglycemia. And when you have hyperglycemia, we are going to have more glucose in the urine. We're going to talk about the effects and the complications. Like when we go to type 2 now, type 2, we're saying we have the insulin, but the insulin is not working. But why is the insulin not working? Because the receptor itself is defective. So here we have a defective receptor. So if you have a defective receptor, our ligand is there, insulin is there, maybe produced in large quantities, in sufficient quantities, but then the receptor is not working, so nothing is going to take place there. Okay, which means that summing up on these two types, they all lead to hyperglycemia, because we are saying that glucose is accumulating in the blood, no mechanism is there to eliminate it. Hyperglycemia. So this glucose accumulating in the blood is going to be excreted from the body in urine. Right? So that's where we have the condition known as glycosuria. This is glucose in urine, right? Or it's a condition we can also call sweet urine. Okay. So for the symptoms of diabetes mellitus, we have what we classify as the 3 P's. The 3 P's. In the 3 P's, we have number 1 is polyuria. Polyuria, we are saying that somebody with diabetes is urinating a lot. Okay. Number 2, we have polydipsia. Polydipsia, we are saying that since this person is urinating a lot, they're also drinking a lot of water, right, to replace the one lost in the urine, and so on and so on and so on. And then the third one is polyphagia. Okay. So as for polyphagia, we are saying that this person, they can't absorb or uptake glucose into their body cells because insulin is defective or it's not working somehow. So which means that these people, they don't have much metabolites for respiration, which means that they are going to have polyphagia. Polyphagia simply means they eat a lot. Why do they eat a lot? Because they always have a feeling of hunger, right? So they tend to eat a lot. That's polyphagia. So these are our 3 symptoms of diabetes mellitus. And then add on also this one is the presentation now. Diabetes mellitus presents as glycosuria, which is sweet urine. Okay, right. So long-standing diabetes can have effects on the body. By saying that somebody has diabetes for 10 years, for 20 years, this can cause atherosclerosis, and this can cause nephropathy, retinopathy, and other conditions like that. So as for atherosclerosis, right, let's go back to ketones and fatty acids. We're saying that insulin here is helping uptake fatty acids and ketones into the adipose tissue cells, right? So when we don't have insulin, we're not going to have uptake of fatty acids and ketones into the adipose cells, right? So which means that fatty acids and ketones are going to remain in the blood, and then they are likely to clog blood vessels, causing atherosclerosis. Okay, nephropathy, this is damage to the kidney, and then also we have retinopathy. So I think this is all I have about the endocrine pancreas, insulin, glucagon, somatostatin, pancreatic polypeptide, diabetes mellitus, and chronic diabetes mellitus. I think this is all. Thank you.